Periampullary diverticula are a common anomaly that present difficulty with the cannulation of the papilla at ERCP. This is a case with several diverticula in the descending duodenum. Here we see a small proximal diverticula and an adjacent large diverticula in the ampullary region. Identification of the papilla in this scenario is extremely challenging. Now let's look for the papilla. We carefully cannulate the sac with the tip of the duodenoscope, and here we see a confusing number of little holes and cavities that might be confused with papillary openings. In this situation, keep in mind that in the vast majority of cases, the papilla is located on the lower rim of the diverticulum or just inside, somewhere between 4 and 8 o'clock. Let's have a look at the anatomy of the diverticula. In the middle, there is a ridge-like structure that subdivides the diverticulum in a left and right chamber. This is usually the bile duct, and the ridge terminates at the papilla. However, here we cannot localize the papilla. But now we know where to look for it. And this is our strategy. We evert and straighten the folds within the diverticular sac by placing traction outside the edge with a cannula. During this maneuver, we always keep an eye on the lower rim of the diverticula to localize the papilla within the folds. Now we get a glance of the papilla at the right lateral aspect of the septum. Here it is, a small papilla that was hidden between the folds at the ridge-like structure. Now we can proceed to wire-guided cannulation of the papilla with a sphincterotome. For optimal orientation of the sphincterotome, keep in mind two things. First, the septum of the diverticulum represents the orientation of the bile duct. Second, biliary direction within a periampullary diverticula is mostly not as acutely angulated superiorly. Thus, it is not necessary to angulate the sphincterotome as acutely upwards. After injection of some contrast that opacified the pancreatic and bile duct, we advanced the guide wire in the common bile duct. Guided by the wire, the sphincterotome is now easily advanced, and the common bile duct is contrasted. There is some floating structures inside the bile duct, suggesting some small stones and gravel. In a next step, we have to perform sphincterotomy to prepare an adequate exit for the sludge. As the bile duct is clearly visible and the duct is close to the duodenal lumen, sphincterotomy is fairly simple. In a next step, we perform clearance of the bile duct with a balloon catheter. After repeated pull-through maneuvers with the balloon, there are no visible biliary stones left. All you can see here are some air bubbles that move up and down. Since the patient had jaundice and a distended gallbladder at abdominal sonography, we also carefully insert the cystic duct. Gentle injection of contrast shows immediate contrast filling of the gallbladder. This strongly argues against an occluding cystic duct stone. In a last step, we place a plastic stent to guarantee optimal drainage of the bile. This is a very individual decision that is based on the clinical situation with jaundice and considerably bad physical condition of the patient.